Okay, thank you very much. Thank you very much for invitation and for having me. So today I will be talking about dual application of fMRI, and in the first part of my talk I will talk about clinical mapping of language and memory. I will share with you our experience, and later on I will be glad to hear your feedback because we are still struggling, especially with mapping of memory. And in the second part of my presentation I will be talking about studies on social brain. I would like also to acknowledge my colleagues who contributed to this presentation and who are here with me, Kuba and Tomasz, the head of our center. But we represent a bigger group of researchers. So in Bioimaging Research Center, we collaborate with psychologists, biomedical engineers, physicists, cognitive scientists, and also with clinical team. So we are already happy and privileged to have this interdisciplinary team under one roof. And we are equipped both with CT scanner and also MRI scanner, and we conduct approximately 7,000 clinical imaging yearly and approximately 150 research studies. And this is a short snippet of the studies and project that we have been involved over the years. And our work has spanned, as you can see, a diverse array of topics, including motor function, language, attention, auditory, memory, both in neurotypical and neuroatypical children and adults. So we have experience with examining both populations and examining different functions. I highlighted in red topics I am going to cover now. Okay, we already had two excellent presentations about the benefits of using presurgical mapping, so I will just shortly summarize, because we already know that if we have an abnormality, like you are not able to see my mouse, but if we have an abnormality in alloquate part of the cortex, of course we want to be sure that we are able to limit and preserve the regions responsible for language, memory, and motor function. Via doing this presurgical mapping, we want to estimate the risk of post-operative deficits, and if possible, we would like also to guide surgical trajectories. We already heard about language, so we know that it's extremely complex function, and if we think about mapping of language, we should apply different paradigms. And in our center, in fact, we are doing it, so depending on the patient's needs, we can pick one or more different paradigms, and usually what we use is language mapping, naming, and we present sentence visually or auditorily. So, for example, a subject is presented to a sentence, yellow long fruit is a banana. We have verb fluency, so subjects hear nouns, and they are asked to think covertly about verbs. So, for example, they will hear mother, school, paint, coffee, and so on, and they covertly think about mother, like playing, working, and so on. We use antonyms, we use sentence completion, and of course we use also letter fluency paradigms. And in case of language, it is not very tricky, because in fact we can see robust and repeated activation across different language areas depending on the task we used. So here you can see the result of few cases. So a robust activation in left hemisphere in both Broca and Wernicke area. In a second example, on your right, you can see a sentence completion conducted in 2 languages. So we recently started to also investigate patients who use on every day basis at least 2 languages, because nowadays many people are bilingual, so we concluded that it would be also beneficial to study not only 1 language but 2 languages. And in case this person was, it was early bilingualism, it was female, right-handed, healthy female, so we did this for test purposes, and she used Polish as her mother tongue, and she used English on everyday basis, both in family environment and at work. And she did the sentence completion in Polish and in English. And as you can see in red, we have response in Polish. In yellow, we can see the response in English, and in orange we can see the overlapping response. So there is a big overlap, probably because it was early bilingualism. But in case of people who started to learn their second language later, the activation might be more spread, and it might be also visible, for example, in additional language areas, executive function areas, not only in dominant hemisphere, but also contralaterally. So we also recommend to think about testing not only 1 language, but 2 languages, or maybe more if we have polyglots. Okay, so this is another other examples of 2 patients differed with handedness. So on your left you can see female, right-handed. Both patients were diagnosed with epilepsy. On your right you can see a male who were using 2 hands. And we use 2 languages because we use 2 different paradigms. Because we try to see an overlap and then to inform neurosurgeon whether right or left hemisphere is dominant for language, or for example, we can see active areas in 2 hemisphere, which is an example, which is the case of this lady. So we can see activation in right and left hemisphere. And in case of both tasks, letter fluency and verb generation, we can see a nice overlap. Okay, so in case of language, it is not so challenging because the results are robust and repeated across patients. But in case of memory, this is more tricky, and I will be also happy to hear about your experiences. And we all know that the most important cognitive comorbidity of temporal lobe epilepsy is impairment in memory. And unfortunately, the hippocampus, which is a critical structure serving long-term memory, plays also a major role in the generation and spread of temporal lobe seizures. So we have a problem here. Luckily, up to 80% of temporal lobe epilepsy surgery can be effective, but as a result, a lot of patients still can suffer from some memory decline. Another tricky part is the fact that seizure beginning in childhood can disrupt normal hemispheric lateralization, and it can lead to functional reorganization of memory networks. So there are many challenges of memory fMRI. First of all, variables that were already also covered, so neuropsychological variables. So the key point is patient cooperation, baseline cognitive status, and in case of those patients, they have massive problems, some of them with memory. Some of them are under drugs, so their speed and traction is delayed. So this is another problem, that they start to do tasks later than typical people. So it's a big struggle, especially if we design block design and we expect patients to do a task within 30 seconds frame. They are just thinking longer. So also it can result in variable task performance that should be checked also before scanning and after scanning. There are also technical variables, and first of all, across many studies and papers we read to make our own paradigms, we concluded that there is inconsistent activation in medial temporal lobe because people are also using different tasks. So there seemed to be no consensus in regards to presurgical mapping of memory. And of course, heterogeneous methods explain poor reproducibility in some studies. And again, a memory formation is a dynamic and a complex process, so it's not very easy to examine. And long-term memory is made up of explicit memory and implicit memory. So explicit memory allows conscious recall, and it might be further subdivided into semantic memory, so our conscious ability to recall some facts, and episodic memory, which refer to the ability to recall some events which are placed in context and in time. And this episodic memory is built in stages. So first we have encoding, then we have storage, and then we have retrieval. And what studies found is that especially later stages of episodic memory result in more robust hippocampus activation. So probably we want to examine storage and retrieval. But a lot of patients with epilepsy have different memory deficits. So they may have problems with encoding, and it will, of course, result in deficits in storage and retrieval. So it's a big challenge. And also paradigms should be, or selection, the selection of paradigms should be guided by deficits in memory. So first we should examine the patient, then we should pick a paradigm. And here you can see the examples of two popular paradigms. The upper one is used to examine encoding, and this is a deep encoding task. Patients are presented with words. They have to say whether the word is pleasant or unpleasant. So for example, a cat, maybe pleasant, coffin, probably unpleasant. And then in the scanner, they have to differentiate them into old, new. And the analysis will be done after this differentiation. So hopefully, patients are able to remember the words and classify them accordingly. We tried to do this paradigm, and it turned out that after our pilot study, the paradigm was too easy. So then we concluded, okay, it is too easy for neurotypical people. Let's try people with epilepsy. Probably we will find a balance. And then the paradigm turned out to be too difficult for subjects. So it was difficult to do. The second paradigm is word pairs paradigm. So prior to MRI, subjects are presented with pairs of words. So for example, cat, coffin. Then they have 20-minute delay, and then in MRI, they are asked to think about the second word. So cat, coffin. But still there are challenges. So first, the best protocols probably should have two stages, so encoding and retrieval, and they are, of course, time-consuming. And studies already show that using two paradigms can lead to more robust hippocampal activity. But again, people with temporal lobe epilepsy might have already problems with different stages of memory formation. So how we encounter this problem and what we do in Cayetane. So currently we are using two paradigms, but we are still working on them because we are not still very satisfied. So the first one is word pairs paradigm, and as you can see in fMRI scanner we already have these two stages of memory formation. So first it is a block design. Every block lasts for 30 seconds. With a block we present subjects with 8 different pairs, and blocks are repeated 6 times. And then we have recall phase. So we present one word, and we ask patient to recall the second one overtly. And we are also using a second paradigm, which gives us more robust activations, and this is spatial memory paradigm, and the choice was based on the fact that hippocampus is also implicated in spatial navigation. So the task is, so we inform the patient, we train it before the scanning, and we inform the patient. Think of all the places you pass along the way when you go from your house to the church, from your house to the shop, to the school. And we have 10 different locations that should be present in every town or city, because we have patients from different locations of Poland. This is, again, block design. So it is quite simple, and we try, we also inform patients that this is very important for them to vividly recall all the places they pass along the way. And here are our results. So here you can see the results from examination of right-handed young male diagnosed with epilepsy. In green you can see the activation in result of remembering pairs of words, and orange represent recall phase. So as you can see, the regions or the activation overlaps, but it's not hippocampus, it's mostly more parahippocampal gyrus. So our results varies depending on patient's condition, and this patient, he cooperated very well, he remembered everything, and he was just excellent in a scanner, but this is what we get. And in case of spatial memory, our results are more robust. So again, you can see 3 different cases, all subjects diagnosed with epilepsy, both male and female, differing with handedness. And in all subjects, we were able to see hippocampus activation. In some subjects, we could see laterality, and it was present and it was obvious. In some subjects, we could see activation in right and left hippocampus. So the laterality varies across individuals. So to sum up the first part of my talk, in case of language network activation, we are quite satisfied. So we can see consistent, repetitive engagement of core language regions, and the results can be probably directly translated to clinical practice and neurosurgical planning. In case of memory paradigm, we can see big variability, so we are not yet satisfied with the results. We can see big inter-subject differences in activation patterns. Overall, signal activation is smaller, it's less robust. We can see, so also expected memory-related regions are not always recruited, despite patients' cooperation during scanning, and successful word recall confirmed post-scan. So this is a big problem. And usually our surgeons would like to have multiple paradigms, so they send us patients and they want both language and memory. So it's also tricky how long the procedures should be, because these are patients, so they don't want to be in the scanner for hours. Okay, so now I will move to the second part of my presentation. So now I will share with you one of our projects related to social cognition, and this is one of my main scientific interests. So why to study social cognition? It seems to be obvious, because we are social by default, and in order to navigate like social realm, we need to effectively and quickly be sensitive to social cues, we have to understand them, and we need to react to them accordingly. And also our brain is naturally wired to engage in social interaction and understand social cues, even from a very young age. And what is more, also social impairments are a very typical marker of a lot of psychiatric disorders. So that's why we are interested. And one of the very useful skills that we all use is emotional regulation. And emotional regulation is the ability to control our emotional state in terms of valence, intensity, or duration. And I just picked this picture because in our realm, scientific realm, probably all of you encountered reviewer number 2, and probably all of you feel sad and anger. So how can we encounter it? We can use 2, or maybe more, but usually 2 emotional regulation strategies. One is less optimal. This is called suppression. So you can just suppress your expressions. So you will feel still anger and frustration, but your expression will be just fine. And the second one is cognitive reprisal. This is more adaptive and more effective, and it helps you to, in fact, down-regulate your emotions. So you can think, this criticism will help me identify gaps in my research and make my work stronger. Because of this, I will become a better scientist. So, of course, we all think and we apply this cognitive reprisal when we read the reviews made by reviewer number 2. But a lot of patients, especially with borderline personality disorder and anorexia disorder, they use maladaptive emotional regulation. So they are not able to effectively deal with their emotions. And there are many studies on that subject, and in general, scientists showed heightened emotional reactivity in both groups and impaired cognitive control. It might be seen both in their behaviors and on brain level. But no study has yet examined the neuronal correlates of specific emotional regulation strategies in response to disorder-specific stimuli in both disorders. So for us, this specific stimuli was this picture with reviewer number 2. But for patients, they are more sensitive to other cues. So for example, for subjects with borderline personality disorder, they are very sensitive to impersonal conflict or rejection cues, or for example, self-harm pictures, because they frequently are involved in some self-harm activities. For subjects with anorexia, very emotional cue is related to body image, photographs, high-calorie food images, or the image of weight. This kind of images, for us, probably not so emotional, though for women probably emotional, but to some extent. But for them, very emotional. So we examined three groups of people: healthy controls, women with anorexia, and women with borderline personality disorder. This is just a quick overview of the paradigm. So it was more complicated than in language and memory studies, many conditions, many instructions. So in general, participants were instructed to either passively observe a series of pictures, so the instruction was just look at the pictures, or they were asked to use 2 different strategies, so reprisal or suppression. And before the scanning, they were trained to do so. We also use active control conditions, so it was not fixation cross, it was counting block. To down-regulate their emotions and distract them from feeling overwhelmed. And we applied 2 different analyses, whole brain analysis and also region of interest analysis. Here you can see the regions that we used for analysis. They are implicated in emotional regulation, inhibition, suppression, and executive function, so everything that we need for emotional regulation. And the study, as you can expect, was quite complex, so I will just focus on key results. So whole brain analysis showed that bold activity in the subjects with anorexia in response to anorexia-specific stimuli compared to healthy controls for reprisal versus passive viewing led to increased activation in supramarginal and angular gyrus and precuneus. And those for you who are familiar with resting state probably should quickly realize that those regions are part of resting state and default mode network. So probably, and they are also implicated in self-referential thoughts. So maybe they were reflecting more on the pictures. And there was also lower activation in inferior frontal gyrus, which is also implicated in executive control and inhibition. So they were reflecting more, and they were less probably effective in downregulating their emotional arousal. In subjects with borderline personality disorder, however, we found increased activation in comparison to healthy controls in response, again, to their specific disorder stimuli in anterior orbitofrontal cortex. And again, this is an interesting finding because this region is not only involved in executive functions, but also in reward processing. So maybe those pictures of, for example, self-harm, they were in fact rewarding for them. And it was also showed in previous studies that self-harm can serve as a tension relief activity. So that's why when they saw those horrific pictures, they felt like it was a reward for them. So probably those studies showed us an underlying mechanism of problems with emotional regulation. So to conclude, so our data confirmed the task effectiveness and highlighted distinct patterns across groups in strategy use. So probably the follow-up study will be to think how can we translate it into clinical practice. And we found atypical emotional processing in both subjects with borderline personality disorder and anorexia disorder in response to condition-specific stimuli. Okay, so thank you very much, and thank you, Bergen, for having me. It's really beautiful location. Okay.
Thank you. I think we can probably manage a quick question if there is one from the audience.
Yeah.
Thank you very much for especially the memory part, because we've been trying to do memory paradigms with many disappointing results.
Yeah.
So I have just two technical questions to you, please.
Maybe I should give you this back.
So the first question is, do you have experience with spatial memory encoding? Do you think this would be also helpful to add to the paradigm? Because what you do with spatial memory is that you just assess recoding, not encoding.
Yes.
Yeah.
So in the literature, I saw some examples of paradigms. So, for example, I'm not sure whether you are familiar. Probably you are with Corsi task. This is a neuropsychological test. So we were also thinking to maybe to apply to edit, but we haven't started to do it. So I can't share any results. So maybe it might be a paradigm that will cover more both encoding and retrieval. Yeah, this is what I showed you. These are the examples of studies that showed us something. Yeah, we have also multiple other paradigms that weren't effective at all. So I just didn't want to show you just a brain with no activation. So yeah.
You do encoding and recoding.
Yeah, both.
In the analysis, do you separate?
Yeah, we separate them.
And what's your experience in terms of which one gives you more?
So Really depends on the subject. So this subject, as you can see, the activity is tiny. It's in hippocampal gyrus and it overlaps.
Yeah.
But in some subjects, we can see bigger activity in encoding, in some in retrieval. So I cannot give you a conclusive response. Our experience are really it varies across subjects, and in some subjects we are not able to effectively do it because they are just too slow. So they see the instruction, and because with each of them I work before and I check their neuropsychological status. I do also some trials to check how they can, follow instructions and how effectively they respond. And in some of them, they are really slow, so then it's difficult. In some cases, especially for language, we did resting state language, resting state paradigm, and we were quite successful in identifying language networks. We haven't done it with memory, but I'm not sure whether it would be easy and conclusive.
Okay.
Yeah.